Good afternoon, everyone. My name is Dr. Eric Toring. I'm the Senior Vice President of the American College of Veterinary Preventive Medicine, and I want to welcome you today to today's webinar. Today's webinar is sponsored by the American College of Veterinary Preventive Medicine and its partner organizations, the American Association of Food Safety and Public Health Veterinarians, the National Association of Federal Veterinarians, and the U.S. Animal Health Association. This time, I would like to turn the microphone over to Dr. Suzanne Thomasy, the chair of the ACVPM Continuing Education Committee.
Hello, everyone, and thank you for joining us for today's CE webinar. Today, we have three speakers, all from Banfield Pet Hospital. The first speaker will be Dr. Emmy Sato. She is a senior manager for the veterinary affairs team at Banfield Pet Hospital. She joined the Banfield team in 2013, initially to support Mars Pet Care, Pet Nutrition business units, and then in 2018 to be Banfield focused. As a veterinary epidemiologist, she leverages Banfield's electronic medical record data to improve understanding of pet health trends across the United States and conduct analytic research primarily to produce actionable and implementable insights for the delivery of quality veterinary care and improve patient outcomes. She was granted diplomatic status by ACVPM in 2008 and epidemiology specialization in 2009. She's an alumnus of the University of Wisconsin-Madison, University of Pennsylvania, Emory University, and the University of Colorado. She's currently enrolled at Thomas Jefferson University studying applied health economics and outreach research. She is excited at the opportunity to learn from human healthcare arena and identify what might be useful to pet healthcare and to bring together her background of epidemiology, veterinary medicine, and business. Our next speaker is Zenda Topjohn. She's a senior data analysis for the veterinary affairs team at Banfield Pet Hospital. In her role, she leverages Banfield's expansive database to deliver in-depth medical insights and reporting to various partners throughout Banfield and Mars Pet Care. She received her Bachelor's of Science in Business Administration and a Business Administration degree in 2015. With 2 concentrations in business analytics and global business management, and is currently pursuing her master's in data science at Northwestern University. And our last speaker is Dr. Marissa Rothenbaum. She is a senior manager for the veterinary affairs team and currently serves as the interim director of equity, inclusion, and diversity at Banfield Pet Hospital. As a veterinarian at Banfield Central Team Support, she is passionate about supporting Banfield's associates to promote quality and efficiency in their daily work. With a previous focus on safety event reporting and continuous quality improvement, today she supports clinical skills development for hospital associates and leads the strategy for equity, inclusion, and diversity. Marissa is passionate about diversity, equity, inclusion in veterinary medicine, serving as an officer in the Multicultural Veterinary Medical Association and a working member of the Diversity Veterinary Medicine Coalition. Her hobbies include baking cakes, paddleboarding, and surviving raising a toddler. She's a proud graduate of the University of California education system, earning her doctorate from UC Davis and bachelor's degree in biology and psychology from UC San Diego. Thank you to our speakers, and you may take it from here.
Thank you, Dr. Thomasy. Hello, thank you everyone for joining us this morning or this afternoon, depending on where you're joining us from. We'd also like to thank the ACVPM and other partnering organizations for making these webinars possible and providing us the opportunity to share some of our work with you. As I was introduced, my name is Emmy Sato, and I'm a veterinary epidemiologist at Banfield. I feel very fortunate to be able to utilize my skills in the companion animal space and having access to the electronic health records of millions of pets. This gives me much opportunity to play with data without having to design experiments or clinical trials to identify how we might improve pet healthcare. I am joined today by Ksenia, who will give you some insights into the how we are able to utilize our data. And then Marissa will share how Banfield utilizes the various sources of information in our network to drive quality improvement in our hospitals. And we'll, of course, be using anesthesia as our case example today. And while the three of us work for a large corporate practice with access to large amounts of data, the one take-home point that we hope that you get today, amongst everything else, of course, is that there's nothing Banfield specific about what we're going to present. Any animal health location, whether you're a veterinary practice or not, whether you're large or small, you can incorporate these methods and tools into your practice or to your facility in order to monitor and improve veterinary quality. So just a little bit of background for those of you who may not be as intimately familiar with our practice. Banfield Pet Hospital, we were founded in the Pacific Northwest, specifically in Portland, Oregon. We are currently now headquartered in Vancouver, Washington, so just the other side of the Columbia River. Our first hospital was started in 1955. And since that time, we've grown to be over 1,000 veterinary hospitals located within 44 states, the District of Columbia, Puerto Rico, as well as a veterinary school in Mexico City. As many of you are probably familiar, most of our clinics are located within PetSmart stores, but we have a growing number of standalone clinics. Within our network, we have over 3,600 veterinarians, as well as other team members, which include practice managers, licensed veterinary technicians, veterinary assistants, and client service coordinators who provide the care in our hospitals, which have a primary care focus. And to just give you a little bit of a scope on the volume of our caseload, in 2021, we saw over 2.8 million dogs and over 600,000 cats during almost 10 million pet visits to our hospitals. So just a little bit of information for us to play with in 1 year alone. As many of you may be aware, we are part of Mars Incorporated. So Mars owns a large number of pet health and pet care brands around the world. So we're part of a larger pet care ecosystem, which includes businesses such as VCA, Blue Pearl, Royal Canin, Antec, Greenies, Whistle, and Wisdom Health, just to name a few. And for those of you who've heard about Banfield and heard some of the rumblings for quite a while, we have an electronic medical record system, which has been in our hospital since the mid-1990s, and every hospital utilizes this medical record system as they are brought onto the system. And so, as you can imagine, with having this in our hospitals for over almost 30 years, we have access to pet medical records of over 20 million dogs and cats that people like me get to play with. And Ksenia will provide more insight about petware and their data in a little bit. And from the information that's put into petware by our hospital teams, we're able to analyze that data for some publications that you may be familiar with. And these include things like looking at pet health trends across the United States, and this is reported through things like the State of Pet Health reports, which was an annual report that we generated from 2011 through 2019 to share with the veterinary industry as well as for client education purposes. We've also been able to utilize our data for some traditional epidemiologic research, such as looking to identify risk factors for conditions such as feline chronic kidney disease, periodontal disease, and adverse vaccine events. We've also been fortunate to be able to have access to data to do some proof of concept studies into things like syndromic surveillance. And in the last few years, we really started focusing more on how can we utilize the data to improve veterinary medical quality within our hospitals and improve patient outcomes. And so this led to the generation of reports such as the Veterinary Emerging Topics Report, or the VET report, which has been generated annually since 2017 in partnership with the North American veterinary community, and it launches at the annual VMX conference in Florida. And so the latest report on implementing safety and quality improvements in veterinary medicine was just released a couple of weeks ago. And then, of course, one of the things that we have been focusing on is anesthesia safety, which is the topic of our presentation today. So we've had anesthesia safety on our radar for a number of years. And in 2017, we published a paper in JAVMA looking to identify risk factors associated with anesthesia-related deaths in our dogs and cats that we see in our hospitals. And in that study, we were able to find that on average, our hospitals experience about 7.5 deaths per 10,000 anesthetic procedures performed. And in dogs, that equated to about 5 per 10,000 procedures. And in cats, that was about 11 deaths per 10,000 procedures. We also were able to identify other risk factors that were associated with mortality. And these included things like the recording of an ASA risk score, which is an anesthetic risk score developed by the American Society of Anesthesiologists, the pet age, the type of procedure, hematocrit results, as well as the body condition score. Now, some might think that 5 per 10,000 and 11 per 10,000 is pretty low, which it is. But we recognize that anesthesia is inherently risky. And as veterinary professionals, we feel like it's the riskiest service that we probably provide. And our hospital team perform over 1 million anesthetic procedures in a year. And so while we could see, based on our study, that the mortality rate that we were reporting was at or lower than those previously reported in the Dyson and Broadbelt papers, we felt it's still our responsibility to our pet patients and to their owners to do what we could to further reduce the mortality rate in our hospitals. And while we recognize that we'll never be able to reach 0 deaths, we feel like we should do what we can to identify those risk factors and appropriate mitigations for pets undergoing anesthesia. With the publication of the study in 2017, we wanted to provide adequate support to our hospital teams for providing safe anesthesia. So this included at that time working with veterinary anesthesiologists to update our anesthesia and analgesia guidebooks. These are just a nice, ready reference of medical quality standards and anesthesia protocols for the more common kinds of scenarios that a veterinary team may see in general practice. And the medical quality standards include anesthesia clinical essentials and best practices, which I'll talk about a little bit more on the next slide. In addition to that, we developed some training materials for our hospital teams, such as standards, huddle cards on the standards for our hospital teams to review and discuss during team meetings. We created some job aids for them as well for every step along the anesthesia path for a pet in our hospitals. And so these include things like anesthesia equipment checklist, a pre-induction timeout checklist, a clinical pathology or pre-anesthetic evaluation, including critical stops, and then, of course, other steps along the way. Along with those materials, we also created an anesthesia dosage calculator, which is basically an Excel-based calculator where the team is simply able to enter the pet species and weight on the day of their procedure. And they are provided a quick, ready reference of the appropriate volume or range of volumes for any of the more likely medications that that pet may need during their anesthesia stay. So from induction all the way through anesthesia recovery. This calculator is regularly updated to ensure that our doctors and our hospital teams are providing the best care based on current knowledge. And the calculator was most recently updated last summer. Now, while we developed a lot of these materials with our hospital teams in mind, we also feel it's our responsibility to share this with the industry because there's nothing proprietary about the information that's provided. It's more of a nice, ready reference for everyone. And so all of these materials that we've provided to support anesthesia safety in our hospitals are freely available to the profession on the Banfield Exchange website that's listed on this slide. As I mentioned on the last slide, with the updated anesthesia and analgesia guidebooks, we developed some clinical essentials and best practices. And clinical essentials are those standards of practice that constitute the minimum acceptable level of care. Best practices are those practices that meet or exceed an expected level of care. And so best practices can encompass a scale of care from anywhere from desirable to aspirational. And so with these materials that we developed, we really wanted to embed anesthesia standards within our hospitals and created clear expectations of care for our hospital teams. And so all of these materials were launched in the fall of 2017. And hospital teams were notified that they were expected to adopt and be held accountable for practicing these standards for every anesthetic procedure within 6 months. And with that, starting in in spring of 2018, we implemented an annual technical audit program where hospital teams were evaluated on their compliance with the anesthesia clinical essentials. And as you can see from the graph on this slide, between the launch of the clinical essentials and into 2018, we really didn't see a noticeable change in our anesthesia mortality rate. And so in the fall of 2018, taking the findings from the spring's technical audits, we took a change management approach to further bolster the safe anesthetic practices in our hospitals. And these were through things such as periodic focus areas and hospital checklists. And so as you can see from our graph, since the fall of 2018, we've seen a gradual downward trend in our anesthesia-associated mortality rate in our practice. And on this slide, which is my last slide before I turn it over, I'm just presenting to you two examples of some of the change management tools that we have shared with our hospital teams. On the left is a periodic focus area presenting medical quality standards. And this just ensures our hospital teams stay up to date on recommended practices and understand the why behind why those are standards. The image on the right is the Anesthesia Clinical Essentials Checklist. And this enables hospital teams to review how well they've adopted the clinical essentials into their routine anesthetic practices and to basically identify strategies to to incorporate some practices better that they may not be doing routinely and to celebrate those that they are doing routinely. And with that, I'll now turn it over to Ksenia, who will share with you more about how we utilize data to monitor anesthesia mortality across our practice. So Ksenia.
Thank you. Next slide, please. So as Emmy gave you a brief overview of how petware data is used for our research, I wanted to further expand on our data pipeline from collecting data to analyzing it, and then to finally reporting. Petware is our proprietary practice management and electronic medical record system. It is very versatile and functions as everything from an appointment scheduler to ledger and billing. It is used from the start of the reception when a patient first checks in to when they move into the exam room, when the doctor is creating a treatment plan, and when they're performing surgery. Then it is used to close out that visit through the checkout process and bill the client. It also allows our hospitals to share patient records amongst each other if a client chooses to visit a different location, whether they moved or they just want to try somewhere new. All of the visits data from 1,000+ hospitals is then uploaded and backed up to our central data warehousing system each evening. So this data is subsequently available for operational support, quality improvement efforts, and health research. We use a variety of end user reporting platforms. So sometimes we'll use Excel, business objects, but Microsoft Power BI is our primary tool. The data is synthesized and analyzed to build out dozens of medical and operational reports that are then made available to our field and central team support office leadership on various metrics and goals. Now, if you're a practitioner who's listening to this, you might use a different system to store information. There are still many tools available for monitoring and reporting, depending on how you collect this information. Excel is probably going to be the simplest method. While Power BI and Tableau are tailored for visualizations and big data reporting, they do have free limited versions available to download on their websites. Next slide, please. So one metric that we monitor is called anesthesia-associated mortality rate. And this is a simple calculation that does not require a lot of data for monitoring. Our anesthesia-associated patient death reports are tracked daily, and they're aggregated by each reporting period, which is about 28 days, so almost a full month. Anesthetic-associated deaths is defined as a death that is excluding euthanasia, and it happens within 7 days following administration of anesthesia. Each death goes through a review process to confirm if it was anesthesia related. If not, then it is removed. The calculation itself is very simple. We count the number of deaths as our numerator and divide by the total number of procedures performed. These procedures will include dentals, spays, neuters, and other surgical procedures. Finally, for our purposes, because each hospital performs a different number of procedures than the other hospitals, we look at the number of deaths per 10,000 procedures. So deaths are very rare, and you can see on the top right chart there, chart A, it has a lot of variability and it is jumping up and down. So to find a trend, we aggregate the past 13 fiscal periods together, which is almost a full year's worth of data, into a moving average or a rolling average. So in chart B on the bottom right, the line is smoother and we can start assessing how our efforts are improving safety and quality for our anesthetic procedures from the start of 2017 to now. This is great for long-term trending, but it does lack immediacy in identifying if the rate spiked recently. It doesn't point out that the last month was abnormal. So looking back at chart A, where mortality rate had high variability when looking at it per period, we decided to trial out a new method. So last year, we started to utilize a process behavior chart. Looking at the current line, we can see that P5 has an uptick. Without any indicators on what is considered normal variation, our field leaders may spend quite a bit of effort investigating only to find out that nothing out of ordinary happened in that time. Now, with the process behavior chart, we can add threshold limits that can help us identify easier if one period was abnormal. So now you can see that in P5, that data point is above the upper limit. This means that the chances are pretty high that an investigation in P6 will help identify something that happened in that previous period. The limits were calculated based on the historical mortality data. The central limit is the average periodic mortality rate over time, and then over a specific time frame. And then the upper limit and lower limits are statistical levels based on periodic variability over that same time frame, and they capture 99% of what's considered normal fluctuations. These limits are then calculated for the practice, regional, and market level views. So with process behavior chart, there are 3 ways to identify an anomaly. The first one being when the data point is above or below the threshold limit, as in my earlier example. The second is when 3 of the 4 consecutive data points appear closer to the upper or lower limits than they are to the central limit line. And then finally, the third one being slightly more longer term, when 8 consecutive points appear on the same side of the central limit. This type of reporting allows our field leaders to monitor closely and identify quicker if they need to investigate further. So process behavior chart is not a new method. There are many resources available online where you can download a spreadsheet that can help with these calculations. Many industries use this type of method to help with anomaly detection in their processes. And so far, we've received positive feedback from our field who utilize this chart, and we're learning how they use this tool with other reports to monitor and hold conversations with the affected markets and hospitals. And so we're looking forward to continue learning from this method this year. Now I will pass it on to Marissa to share with you our systems thinking approach to supporting our hospitals.
Thanks, Ksenia. Next slide, please, Emmy. So I'm going to talk about some of the other tools and resources that we developed to support this concept of systems thinking. Historically, in veterinary health in particular, and I think this is probably the same with human health, though they're a little further on in this evolution, there had been a lot of blame placed on the doctor and a lot of, mental health, that strain that can come from these moments where something goes wrong, and then we go in our heads and we beat ourselves up about all the things that we did wrong. And we recognize that that's really detrimental to the long-term sustainability for us as veterinarians in this profession, but also just in terms of really seeking to understand what are the things that are happening in our hospitals and how we can implement some systems-wide changes to reduce the risk of these adverse events occurring. And I know Emmy had mentioned it at the top of our presentation, but I do want to emphasize that you do not have to be at a major corporate practice. You do not have to be in general practice to start to employ some of these concepts wherever it is that you are operating. So I will first go into a little bit about our journey as Banfield, review some of the tools, and hopefully you will spark some interest in how you might be able to bring this to your work. So first, the very foundational element of this is the culture behind these concepts. We can push out all the tools in the world, but if we really can't engage the hearts and minds of our teams, help them to understand why this is valuable, we don't get good adoption. So in 2015, it was the beginning of our quality program, and our quality journey in earnest began with a roadshow where our quality leaders went to each of our regional meetings, met with our leadership at the regional and field level to help them understand what is this concept of a culture of safety and how might they start to bring it to life. So that was before we did anything, before we pushed anything out, we wanted to get that culture in place. And then from there, the following year, we were able to start to actually drive continuous quality improvement by gathering some input from our hospitals to understand what's happening at the hospital level. We have over 1,000 hospitals nationwide, and there can be a lot of variability, but what can happen is you get this impression, if you're just one doctor at one hospital, that that's just a one-off. This thing that happened was purely accidental, whatever happened. But when you start to look at it at that national level for us, you start to see that these one-offs are happening across the practice and may indicate an opportunity for a true central systemic change to policies, procedures, tools, or resources that might help reduce the risk of these events from occurring again. Additionally, we wanted to shift the culture. Another thing that our field has been is historically patriarchal in terms of the hierarchy in the hospital, and the doctor kind of rules the show and they call the shots and they make the decisions on all the things, which is appropriate from a medical standpoint, but not always the best way to build safety. So we created associate empowerment through a few different tools. First, the concept of stopping the line. And this comes from factories where they literally stop the production line if there's something wrong, and they do not start it again until that has been addressed. But we wanted to build into our associates the concept that same thing applies to us. If we're working with a pet and there seems to be something that does not feel safe or feels risky, any associate is empowered to say, stop. We also wanted to help give them almost like a script to be able to speak to this when they choose to stop the line, which is where the CUS communication guide comes into play. And you can see it in the box there. I am concerned, I am uncomfortable. This is a safety issue. And you can see CUS is highlighted. They loved it because we got to talk about cuss words and cussing in the hospital. And it worked really well so that when say a client service representative from the front desk sees something like a pet seems really stressed and they are worried about that pet's safety, they are able to say, hey, let's stop the line for a moment. They have this script that makes it easy for them to raise their concerns. But that scripted language is also a really nice trigger for the rest of the team to stop and listen, because they're saying it in a clear way and they understand they need to slow down, hear what the concerns are, talk through it before they move back to action. Other hospital tools that we built out, we're seeking to help our hospital teams identify what are issues that they own at the hospital level. Things like the policy is clear, but people aren't adhering to expectations. So it's behavior-based. That falls heavily on hospital management to dig into associates that may not be doing the things that are clearly expected of them. versus things that are central based issues. The policy doesn't exist, or the policy itself is flawed and is setting the wrong expectations of our teams. Those are things that we can address at our central team support office versus something that is well beyond our control centrally. So we wanted our hospital leaders to start to understand, when can they just lean in and have these conversations? When should they? And not just say, this is a problem, please fix it for us, when we are unable to do that centrally. We also created a quality toolkit, and those boxes on the left-hand side are a few of the tools that are contained within that quality toolkit. And it's very robust. It helps our hospital leaders understand why an event may have happened. So that's top left one, there's the Swiss cheese model, which I'll go into a little bit greater detail, but it's more of like a diagnostic tool of like, what was the breakdown? You have things like the one with the hexagons there. That is a resource to help guide teams through when an event happens. What are all the steps they need to take to make sure the people are taken care of, the pet is taken care of if it's not a death, the client is being communicated with effectively. And a big part of that is taking care of ourselves as the doctors, the ones that are largely responsible, but also taking care of the team, because this can have significant mental and emotional impacts to teams when these unexpected events happen. And we wanted to really help the teams understand it's okay to slow down, step back, take that time to gather yourself. Don't feel like you just have to forge ahead, because that's not always the best decision for everyone. Doesn't necessarily support the overall process. And then lastly, below that, there's another tree that you'll see there. And this is based off of a, blanking on what it's called externally. It is from human healthcare. Oh, the just culture algorithm, sorry. And it looks at, if we do figure out that an event ultimately boiled down to an associate behavior, a decision, an action, it looks at that associate's action to determine if it is truly something that they are at fault for. So it looks at, did they do this intentionally? An intent to harm a pet, certainly problematic and something you'd want to dig into, not a systems issue. Is there something else going on that affects their ability, like incapacitation due to drugs or alcohol, or even a prescription medication that might be affecting their performance? And then moves through, what are the procedures and guidelines? And then from there, the substitution test, which is the part on the gray there, helps to understand, okay, maybe it is systemic, and what do you do in response to these things? So that's really helpful to ensure that our associates are treated consistently and fairly, regardless of which hospital they sit at. So it starts to eliminate some of the variability that can occur when these more subjective evaluations of associate behavior happen. We also created some tools that we use centrally. And we also trained on some processes as well. So a root cause analysis, and we have done the very, very robust deeply academic root cause analysis. And then we have sort of a quick assessment root cause analysis tool as well. We also use something called the failure modes and effects analysis. This is a great resource, for example, when we're considering a new piece of equipment, to look through what are all of the potential ways that that piece of equipment could fail, and how might that affect it, so that we can really understand what are the risks ahead of time. And then fault tree analysis is similar to a failure modes and effects analysis, but again, looks at all the different ways a given process can break down to help identify where we would have the most impact if we were to address that situation. So really helps us to prioritize our resources to addressing an issue at the most impactful part in the process. And then lastly, the domains of quality that you see there on the bottom right, they're also in our backgrounds. Those are also adapted from human healthcare, but those help give our associates a framework and help them recognize that quality is robust. It is also everyone's job. Quality for us as a large organization for a long time had sat with the veterinary team, but this is also responsibility of our operators, our finance people, our commercial folks that are sourcing equipment and products for us. And this helped to really elucidate what are all the elements that go into quality care. So that is a helpful framework that we frame up a lot of our communications in as well. Next slide, please, Emmy. So I mentioned the Swiss cheese model. This is a little bit dated in that there is now a newer option for you, but you can access this. The most recent Banfield Vet report includes the Swiss cheese model worksheet as well, but you can also find it on an old Today's Veterinary Practice article. So this helps you look at what are all of the potential protective layers that should have prevented an event and figure out where did we have holes in our Swiss cheese, gaps in our processes that enabled this event to occur. And that helps you to understand where you could implement change to reduce the risk of repeated adverse events of this nature. You will see that the very last slice on this Swiss cheese model is human error. We are not a production line that is staffed entirely by machines. We are actually people, and every system must be designed with that human error element in mind to work around that human error. We can never eliminate it because we are people. People are innately flawed. We accept that as fact and try to just build the best system as possible around that. Next slide, please. So I'd mentioned a little bit about some of the processes that our teams go through when these adverse events occur. And I wanted to talk a bit about the clinical learning and support process. This is a revamped version of a legacy process. We used to call it peer review. And the purpose of this process is to understand some of the events that are happening when major events like anesthetic deaths occur, for example. So there's still an element of we are pulling learnings out of the process, but we made a few changes to the process to help strengthen our ability to really understand these events. So in terms of clinical learning, historically, this case review essentially had happened centrally. So we are, in some cases, literally thousands of miles away from an event, and we are interpreting the nature of the event based on what's documented in the medical record. And sometimes medical records do not show you all of the things. They don't show you what was happening around them in the hospital, what was some of the decision making. You just see the final decision. You don't see all of the associates that were involved in the process. And it made it really hard to truly understand what were some of the root causes of these events and ensure that the learnings we were pulling out were accurate. So we decentralized this conversation, this exploration, to our local leadership, and they're performing one of those not fully in-depth root cause analyses, but something a little bit higher level, just to help them understand what was the situation and help them to try to identify some of those root causes. But by shifting that investigator closer to the event, we're able to better explore what was happening. They can talk to people to get information and really strengthen the confidence in whatever root causes we are identifying. The other thing that we started to do is using the term sentinel event. And these are events that may indicate a significant issue that happen only as those one-offs. But one-offs, yes, they may just be this, weird combination of events that led to this, but sometimes there is something hidden in there. So we not only are watching what types of events are occurring, but within this process, Ksenia had mentioned this before, people are able to say, hey, this particular death wasn't actually anesthetic related. Please remove it from our reporting so that we truly can identify what are the deaths that are happening as a result of anesthesia and what are just some of those really poor situations where things just happen in a very untimely way, such as a dog gets hit by a car 6 days after its dental cleaning, otherwise healthy, unremarkable dental cleaning. And that can happen. And the way that our system is set up, it would flag that as an anesthetic death. So we wanted to ensure that we were able to eliminate those that are not truly anesthetic deaths. And then the other element that was new with this process was the concept of associate support. Again, mental health and emotional strain associated with the work that we do is real, and it's real for all of our associates. This is not just a doctor problem. This can affect even our front desk teams because they know the pet and maybe they're they've known the client for 20 years and we've seen pet after pet after pet and they're attached to the client, and things like unexpected anesthetic deaths can impact everyone. And what we wanted to do was build up recognition of the associate piece. It used to be that this was a conversation that happened behind closed doors with just the doctor. And it didn't bring the whole team into the conversation. It didn't help them to alleviate some of the shame associated with these events. Because a conversation behind closed doors, when that happens in our hospitals, everyone's like, ooh, someone's in trouble. Like, it's not at all a positive experience. It could be really, really stressful for our doctors, but also just sort of shifted the culture around these events. So by creating the time to slow down, ask how the associates are doing, dig into any additional support needs. We have great resources from our health and well-being team. We've got our suicide prevention or recognition program. We have our associate support program as well. There's a lot of different resources that we can tap people into, but we don't know that we need to recommend some of these things if we haven't had that conversation. This process actually prioritizes the associate support element over that clinical learning, because that psychological safety can be so critical for learning. If you don't feel safe, you're not going to absorb any of the things that we talk about. You're not going to be able to really change behaviors going forward if there were any concerns there. And then again, that open team-wide discussion, it happens in the treatment area with everybody, because this is not something to be afraid of. This is not something that is shameful. We really want to support that culture of safety. Next slide, please, Emmy. So as I mentioned, we are on a journey. Quality is not a one and done. It's not a finish line that we reach. We are continuously seeking to improve the quality of care that's provided. Continuous improvement never stops. And we are continuing to observe, to ask questions, get feedback from our field, to understand where there's barriers or gaps in providing standards of care. We're continuing to encourage the sharing of best practices, both at the local level within a market, so 15 to 20 hospitals that are all under the same leader, and then as well as bubbling up, what are those really great things that we could share out practice-wide and help our hospital teams promote quality in their daily processes. And then we also have dashboarding that helps our veterinary leaders and their hospital teams just understand what is their performance like? Where do they have opportunities to improve at the local level in terms of quality, in terms of patient care? And we're continuing to perform research centrally. So we've done a study of risk factors associated with feline anesthetic associated mortality, recognizing that cats have an increased risk of anesthetic mortality and seeking to understand what are some of the things that drive that? So we are actually just recently submitted and have been approved for publication on risk factor for feline anesthetic mortality. So that's very exciting. We're continuing to explore the feasibility of AI to predict patient risk. And then also any other opportunities to reduce risk, improve our veterinary quality, and just support our teams in everything that they do is an ongoing mission for us as well. So that is the end of our presentation today. We really appreciate the time for you all to come spend with us. And I know we've got a couple of questions that have come up in the chat. So I'm going to pass that back over to Eric. Thank you.
Okay, wonderful, a fantastic presentation. In a previous life, I had involvement in patient safety, human healthcare patient safety, and a lot of the same concepts, full stops prior to a procedure, during the procedure, anyone in the room can call a stop or point out a safety concern. And I think it was mentioned several times, it becomes a culture of safety where everyone can feel comfortable in doing those types of activities. So fantastic presentation. And we do have a few questions. I'm going to start off with a comment in our chat session from Dr. Mo Solomon. Again, great presentation with the expected way to use epidemiological tools and available appropriate commercial software. But his question, he wonders if our veterinary educators in North America have used these findings to potentially adjust their teaching or to include in their teaching in best practices in anesthesia.
I can take that. And then
Okay.
any if you have other things to add, let me know. So we have worked very closely. There are a number of academic institutions that are digging into patient safety. Florida being one of the universities that we'd worked most closely with when I sat on the quality team and was engaged in this work. That was where a lot of those conversations were going. The other hope is the more that we can talk about it, we can start to set that expectation, especially as we're linking the concept of medical error to the mental health element, which we know is so critical for our field. Emmy, what else, or Emmy or Ksenia, anything else to add to that?
No, I mean, I was just going to say, I mean, I think it's been bubbling in various locations within, I think, the veterinary teaching hospitals. And I think there's definitely been more and more awareness of importance of things like the anesthesia checklists and things like that. And so, I think that it's a growing trend. And, hopefully, as Marissa said, like with us talking about it more and really putting it into place in our hospitals, it is something that becomes more of the norm as opposed to us trying to promote it more and more.
Wonderful. Dr. Suzanne Thomasy has a question for the group.
Hi guys, I really appreciated your presentation. And in my former life, I was a Banfield veterinarian. So I really could appreciate having these tools back when I was in practice in the hospitals. But my question to you, so now my life evolves around occupational safety and health at NIOSH. And so I was wondering, could any of these tools, or have you looked at using any of these tools where associates could put a stop action in place if they're concerned about their safety and health from a worker perspective, not just a patient safety?
Yeah, that's an excellent question. And it was a bit of a surprise for us when we first launched this and started to gather hospital input. We saw a huge amount of associate focused safety concerns. So at least in terms of notifying us of these concerns, I heard one of my old associates at my home hospital had specifically posted on Instagram about using cuss, and she was excited to cuss at work because she had called out someone standing on a stool to get something out of a cupboard. So this does come into place with some of those like very basic OSHA things. We get a lot of, or one of the significant improvements that we were able to make quite quickly as a result of some of our learnings was our hospitals had a standard ordering option for radiology gowns, and they didn't have a size small. And that was a gap because so many of our associates, being predominantly women, were struggling to keep gowns on safely for shooting x-rays. So we were able to actually include a small size gown in response to some of the concerns that were elevated. So I think that these tools apply quite well, especially since so many of them, all of them, were really adapted from human healthcare. And so much of that is the human safety for both the patient and I think the care providers as well. So it's a fantastic question. And I think there's a lot of potential application there.
Thank you.
I was just going to add on to that. I mean, I think, to Marissa's point, there's certainly been things that we've been able to garner from the input that we hear from our hospitals. So things like we happen to change the brand of our syringes that come with needles. And it turns out that those needle caps actually were more likely to be punctured by the needle as the associates were handling it. So that helped us recognize that, hey, we need to change suppliers for our syringes because it's a safety issue. And things like patient safety, but affecting our associate safety of like patient handling and those kinds of experiences as well. And so that has enabled us at the central team to really look at what do we need to do to help improve the safety of our associates as well as the pets. And so we also have on our team, our health and well-being team, we do actually have an occupational nurse who has been really integral in helping to really build up that arm for our business as well.
Okay, excellent. Dr. Connie Austin has a question. With the Banfield Medical Record System, can each practice see reports on the platform to see how they are doing in various aspects, or can that be done centrally? Can local practices develop their own reports?
I can take this one. That's a really good question. And yes, we utilize Power BI as our reporting platform in order to create different reports. So like anesthesia mortality rate, there is some reporting that field leaders can go in and look at the data by market, by region. There's also additional reporting available around dentals and analgesia practices and x-ray practices. And essentially, we also have our own reporting around medical records. So our electronic health records are semi-structured. So in the sense that we collect information around diagnosis and ailments in their structured format, and we can track that through prevalence rates. And we do look at that internally. And at times we do end up reporting it out, like Emmy had mentioned before, like with the state of pet health or a vet report, depending if we start seeing an uptick over the years.
Okay.
And also just to add on, I mean, we through the work that Ksenia and some of her teammates do, there are a lot of reports that we generate through Power BI and as well as other things. And they, depending on what the report is, it's available at different levels. So hospital teams can see some of those measures that are particularly of importance to them that they could really directly impact and see how they are doing. And then there are others that are perhaps not as useful to those hospital teams just because of things like it's such a low volume of cases that there's just so much variability that it's really hard to interpret. So they can at least see where their market is relative and kind of have a better understanding. But the reporting that we put into place is certainly constantly growing. We already, I think, have in the queue a handful of new reports that are going to be coming out in 2022 and 2023 as well in the queue. And I think, to answer what I heard or interpreted as the last question is, again, these are not things that are restricted to our being able to use because we have a large database associated with it. It is that these are tools that are readily available. Certainly things like Power BI, there may be licensing fees associated with it, and it does require a little bit of skills to do that, but it's certainly accessible. And really you can make whatever reports that you want to create and what you want to measure based on the information that your hospital is already collecting or starts to collect.
And I guess, you speak to the reporting, being somewhat flexible and I guess modifiable. One of the questions is there such a process, a feedback process where the electronic health record system is regularly or periodically modified to produce a better format or better data collection for epidemiological analysis?
I think the thing is, really the electronic medical record system is primarily intended to be a medical record system and an invoicing system. So it is developed and built specifically to support our hospital teams. And as a research group, we're just happy to be able to kind of piggyback on the data that's being collected. Certainly we can influence if there are certain things that we want collected or make sure they're collected on every visit. So for example, body condition score was optional for quite a bit of time. And we were able to build a business case of why it's important. And it's not just for research purposes, but it's to improve the patient care that's being provided. And so, we try to find that balance. And, certainly, as I'm sure it's not terribly surprising, we get feedback from our hospital teams quite regularly on what they see as pain points to petware. And so that is feedback that is certainly recorded in our system and as part of our IT teams, a way of trying to identify what changes need to happen or how do we prioritize to help our hospital teams have an easier day or a better day. We certainly don't want to make changes that make things more complicated for them. And so that's always a big factor for us.
Okay, and I'm going to go ahead and just do one more quick question. Someone is curious about the results of the feline AAMR study that is to be published. Do you have any details on that, or can you share any of the results? And then the second part of that question is, which journal do you anticipate it being published in, and when?
So it was accepted for publication, and I believe it's in Veterinary Anesthesia and Analgesia, I think. And I have to beg forgiveness. I've gotten it wrong, because I know we also got notification for another paper as well. And so my understanding, I believe that it is had the latest set of revisions, with the expectation that the next set that we will hear back from them is the proofs. So it should be coming out. I don't have an idea of when, but it has been accepted.
Okay, fantastic. Well, we're quickly approaching our hour, and I don't want to keep our esteemed panelists any longer, but I do want to thank you on behalf of the American College of Veterinary Preventive Medicine for your presentation today. I believe it was very well received, and I do want to pass on my appreciation. And with that, again, thank you, panelists, and I will turn over the final comments to Dr. Tomasi.
Thank you. And thank you everyone for attending today's webinar. Thank you panelists for an amazing presentation. And I just got one last plug. Again, we're always looking for speakers for our 2022 lineup. So if anyone is interested, please feel free to reach out to the ACVPM website and post your recommendations, and we'll work on setting that up. Thank you very much. Have a great day.